Never wants to work the first time. There we go. Okay. So burns can be really minor all the way to really, really severe, all the way to extremely life-threatening and fatal, depending on the size and the degree of the burn. So, I mean, of course, a burn can affect any person at any time. There are over 500,000 people with burn injuries every year. And over 3,000 people die annually from smoke inhalation and fires. So the prognosis varies very, very much when, depending on the patient's age, the comorbidities, and the severity. So, of course, your high-risk patients are going to include the elderly, smokers, just because, well, really, that's kind of an older thing because cigarettes have a, what is it called? Like flammable chemical that we puff inside of our lungs. That if you drop a cigarette like on your couch, it most likely will not catch fire like it used to way back in the day. But still, I mean, people that smoke, they have open flames more often, and things could catch fire. So, and then people with disabilities, neurological illnesses, substance abuse issues, psychiatric illnesses. And one thing that's really missing from this is kids. Kids are a huge, huge high-risk population. I mean, even just speaking from my own personal experience working at Akron Children's, not we, because I don't work there anymore, but they are the only burn center between here and Pittsburgh. And when you have a severe burn, you can't just go to any hospital. You have to go to a hospital that specializes in burns. So we took patients from 0 all the way to, 100. Because at a burn center, you don't discriminate by age. Even though it was a children's hospital, it was the only unit in the hospital that would take anybody of any age. So the classification of burns depends on the depth. So the depth is, how did the injury occur? What was the agent? Because there that will continue to burn your skin even after you wipe them off or try to wash them off with water or soap. There are some specific chemicals that take other chemicals to neutralize that burn. And if you don't neutralize it correctly, your skin will continue to burn. The duration of contact with the agent, the thickness of the skin in the area. So it could be superficial with partial thickness, deep partial thickness, or full thickness. So if you look at the picture, it's showing you the depth of the skin. So you have your first layer, which is your superficial. Then you have this small portion right here, which is your partial thickness. Small portion here, which is your deep thickness. The farther you go down, the more it will affect the nerve function in that area. It also affects your thermoregulation, which is a very significant part of burns, and you'll see that soon. And then full thickness burns is going to go all the way down, really almost to the fascia, or the adipose tissue, which is your fat tissue. So you have your superficial, which is your first degree. This affects the epidermis only. These are super painful because your nerve endings are right there and it exposes your nerves. I mean, we've all had a superficial first degree burn. You touch it, it hurts. Your clothes hurt. I mean, everything just hurts when it touches that area. It's going to look pink, red, and dry. There's going to be tenderness and pain. Blanching is not present. So I hope at this point we all know what blanchable skin is. When you press on the skin and take your finger away, the skin turns white. And then when you take your finger away, the redness comes back. This shows vascularization to that area. So these areas do blanch because you haven't gotten down to that capillary vascular layer and singed it off. And with first degree, you don't have any blisters or scars. This picture actually looks a little bit more. So this is partial thickness, second degree. This affects the epidermis and the dermis. So this contains your nerve endings, blood vessels, hair follicles, and glands. This is your really, really bad sunburn that you're blistering all over. This is last year, actually, I was making steak in the cast iron skillet, and I had Henry in my arms at the stove, which is obviously a big no-no. And I was scooping up the butter to like put on top of my steak. Thank God I put him down because my pan was too hot. And 30 seconds after I put my 2-year-old down, the bubble popped and splashed all over my right hand and arm. And I had huge blisters and second degree burns. It was very, very, very painful. Blanching is present. And then with the scarring, you can have those like shiny scars. But these, we've all probably had second degree burns with sunburn at least. And it's very painful. Then you have full thickness burns. Yeah. I'm gonna switch over to my hotspot just because we all know it's gonna go out, right? Okay. Oh, my hotspot. Can everybody hear me?
Yes.
Might as well solve the problem before it becomes a problem, right? Okay, so now we have our full thickness, our third degree burns. These are the most common burns that we saw in the OR. This affects the epidermis, dermis, and hypodermis, which is where your adipose tissue is. It can look black, red, yellow. It can look a lot of different ways. And when the burn first occurs, especially with this situation, this is probably like straight in the ER, this picture, before they even get to the OR where they're a little cleaned up already. So the charred, dry, and leather skin, we refer to that as eschar. Eschar has to be removed. Okay. You cannot have healthy tissue grow or have a skin graft be capable of surviving if you don't remove that scar. There's little to no pain. Why? Why is there no pain? Yes,
I
but
mean, the nerve endings are
Nerve
burned off
damage.
and nerve
the
damage.
nerves are shot. Yeah, the nerves are shot. It has burned through the entire layer where those nerve endings are. And this cannot in any way, shape, or form heal on its own at all. There has to be medical intervention. So now we have different types of burns: thermal, chemical, electrical, radiation, cold, and friction. Thermal is going to be hot, right? You put your hand on the stove, you accidentally forget to use pot holders, and you take the pan out of the oven and burn your hands. Some dumb teenager is at a bonfire and his friends is like, oh, it'd be so funny if you stood inside the fire. And he stands inside the fire and then his clothes light on fire and then he's on fire, right? These are your thermal hot, hot, hot. Chemicals, we already kind of talked about chemicals a little bit. The chemicals, if you've ever had a chemical burn, like if you've ever used skincare that has just stripped your skin barrier and your face literally feels dry and like you burned your face, that is from a chemical burn. Okay. So, and like I said, a lot of these chemical burns have to be neutralized in some way by some type of base that can relieve the burning and hopefully relieve some of the pain. Electrical, this is going to be from electrical like shocks. Radiation can come from a lot of things. So have you ever had a family member or a patient or someone who was getting radiation treatment and their skin looks red, it looks sunburnt? It's because that radiation literally does burn your skin. And then cold, this is from, oh my God.
Frostbite.
Thank you, frostbite, Jesus. I will never forget, and I actually have a picture of a very, very sad situation of a homeless guy. He's in his 30s, and we had to amputate both of his hands because his hands were so severely frostbitten. And I actually have a picture of his hand in the bucket. And it was really sad because he was so young. And then you have friction burns. We've all, especially when we were kids, we got like carpet burn, rug burn. So if you scrape against that carpet, that's friction and that's causing your skin to burn. Okay. So a little dive deeper into our types. Again, your thermal burn, this is really the easiest one, right? This is hot surfaces, steam or liquids, or obviously fire, okay? Something that's really, really hot. Chemical burn. So this is contact from a toxic agent. Examples could be bleach, gases, drain cleaner. Have you ever tried to bleach your hair at home and you put the bleach on your scalp and then all of a sudden your scalp is on fire? Or have you ever had a perm? Or have you ever had your hair relaxed? When that feeling of your scalp is burning, that is a chemical burn.
Some people would say that's how you know a relaxer is working.
Okay, first of all, I have been watching a ton of Brad Mondo videos, and literally a couple days ago, the girl was putting relaxer on her edges, and she was like, as soon as it starts burning, I know it's done. And I was just like, girl, what?
But now that you say that, that makes a lot more sense because I really thought I was like, that girl's crazy. But no, apparently that's true.
They say stand in front of a fan when it start burning.
Well, apparently, if you go past the burning part, then your hair falls out. So don't do that, Kiki.
Or put some Vaseline around your edges so it
I
doesn't burn.
I saw that too in a Brad Mondo
And on your
video.
ears.
I love, yeah. I learn lots of things on the internet.
Okay, so this is an electrical burn. This is from an electrical current. Of course,
Our cardiac system runs on a electrical conduction system.
so if you get electrocuted, it can cause dysrhythmias and cardiac arrest. That makes sense, right? We use electricity to try to restart the heart when we are in different VFib. So this can happen from power lines, outlets, lightning. And I'm sure it hurts really bad to get shocked, especially so severely like this. This hand, this isn't the most severe situation, but when your hand looks like that, where the skin is coming off of your hand, that is called degloving. And I have seen even really more severe situations of degloving, and it is gnarly. Okay, so this is a radiation burn. So examples of this, bless you, is going to be sunburn, radiation therapy, excessive X-ray, CT, or MRI. And it can affect any of the areas that are obviously subjected to the radiation. So this is your cold burn. Frostbite, when it gets really bad, the skin will turn black and literally like become necrotic and try to slough off. This is a very minor example of frostbite. When you have frostbite, do you want to immediately submerge your hands in hot water? No,
No.
never, 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 never. So you want to slowly reheat that skin. You don't want to immediately emerge into hot water. That, first of all, that would be extremely painful, and it's not good for the tissue. Whenever you reheat a person's body, you want to do it slowly. It's not something that happens really quickly. And then this is a friction burn from skin being scraped or forcibly removed by an object. So this can happen on the carpet like we talked about. This can happen on trampolines, rope burn, anything that is just being like torn from you. It happens a lot on the hands, the knees, the elbows. Any questions on types of burns?
No, can you go back real quick so I can? Right.
Yeah. I didn't think there would be a lot of, I feel like this is self-explanatory with the types.
Okay, I'm done.
So the complications is where things get a little hectic. So we can have cardiac complications, hemodynamic instability, hyponatremia, and hyperkalemia. Why? This is
Fluid imbalance.
Fluid loss, more than just fluid loss. Fluid loss is it's a very, very good answer, but there's a bigger answer. So what happens when we talk about cellular destruction? If you get burned so severely down to your blood vessels and your blood cells become destructed, like cell lysis,
Mhm.
what do you think happens to the electrolytes that are contained within those blood cells? Where do they go?
They get destroyed as well.
They leak out.
So you're losing an intense amount of water, an intense amount of hydration. Okay. And you're going to learn the first step to burn recovery is to aggressively hydrate your patient. And the electrolyte abnormalities can occur because of that cell destruction, because our potassium, the intracellular potassium, isn't meant to be extracellular. If our potassium all of a sudden has been destructed, or our cells have been destructed, that sodium and potassium that was being contained is now free within the blood system and can cause dysrhythmias and cardiac arrest. And also definitely hypernatremia can cause brain death. Hyponatremia has all of its own issues that we've discussed previously. So then we have respiratory issues, upper airway constriction. What happens when your skin gets really, really tight? So that eschar that
said
we were
tight?
talking about, tight. That eschar that we were talking about, that dry, flaky, it's also extremely like leathery and can take on this really thick, fibrous characteristics, which can actually cause constriction. So if you have no elasticity left in the skin and that skin around your neck is swelling, that swelling can't go outward because the skin isn't stretching. So the swelling is going to go inward and collapse your airway.
So like
That can also
suffocation.
happen with your arms, your legs, and your abdomen. It's called compartment syndrome. Compartment syndrome can cause you to lose a limb. It can cause you to lose your airway. It can cause you to not be able to breathe any longer if it's happening within your thoracic or abdominal cavity, because your lungs, there's no expansion. There's so much swelling and the tissue cannot stretch that you're literally suffocating in your own body. And what do we do with compartment syndrome? We have to do what's called a fasciotomy. A fasciotomy, I've only seen it once, and it was so terrible on a poor little 2-year-old that got his legs caught in his bed rails. And they had to have been caught there for hours and hours and hours. And when his dad went in to go get him in the morning, found his legs caught in the bed rails. By the time he got to Akron Children's, his compartment syndrome in his legs was so severe, we had to do fasciotomies on both sides of his legs, on both legs. And a fasciotomy is when you literally take a scalpel and you cut right down. Big slit, right down the leg. Because what the tissue inside is strangulating and the blood flow is stopped. And if you don't get to it fast enough, that muscle tissue will die. Thankfully, we got to him fast enough. Disability, which of course, hands, feet, joints. I feel like everybody has seen a burn victim that has really intense scarring. That scarring we refer to as contractures. And if your hand has scar tissue that is so thick and you can't actually move your fingers or hands, you can't use that hand anymore. You can't hold a pencil, you can't hold a cup. So then if you have severe webbing or scar contracture in your elbow, you're going to have a hard time moving your arm. So this can affect any of your extremities, joints, anything. Infection is huge when it comes to burns, because this wound care for infection or for wounds for burns is so intense. So intense. And it's daily or bi-weekly, maybe 3 times a week dressing changes that are extremely painful. And then you have impaired healing from other comorbidities, which could include diabetes. Oh, you're good. Diabetes, chronic kidney disease, and malnourishment. So you have 3 phases of burns. In the emergent phase, it's the first 24 to 48 hours. This is where fluid resuscitation is really, really important, and thermoregulation is extremely important. This is the onset of injury up until the capillary integrity is restored. The acute phase is 48 to 72 hours after the burn. And this is the onset of diuresis. This is the weeping. So I'm not talking about diuresis from your urethra. I'm talking about losing fluid through these opened wounds. They are constantly going to be weeping fluid. And then rehabilitative, which can last weeks to years, especially depending on the scarring. Not only in the burn center at Akron Children's do they do surgery on the emergent and acute phase, but they also offer laser therapy for years and years and years to try to soften the scars and help contractures so that patients can live their best lives. Fluid resuscitation. In the emergent and resuscitative phase, fluid replacement is the #1 priority. And there is a very specific formula that we use not only to calculate how much of the surface area of a human's body is burned, but also how much fluid resuscitation they need. So we use the Parkland formula, which is used to calculate the total fluid the patient requires in the first 24 hours. And this only applies to like severe burns, 2nd-degree burns that take up a lot of surface area, and absolutely 3rd-degree burns. The rule of 9s is used to estimate total body surface area. Definitely expect to have to figure out both of these Parkland formula and the rule of 9s. This is going to be a big part of burns, management, and your exam. So, the rule of 9s, total body surface area. So by dividing the body into very small areas and providing an estimate of the proportion of body surface area accounted by, you can obtain an estimate. So when the EMS, paramedics, whoever is calling or giving a report off to another provider, they are immediately going to say this person has 36% of their body burnt, 24%, 50%, 70%. And this is how we decide how much. This is especially important when we're talking about small humans, because their total body surface area is so much smaller. So it is divided into anterior and posterior. If you're looking at the entire body part, that is on the, so if you're looking at this would be the left side of your screen, right? So this is the entire part. So if you're talking about the entire head and neck, that's 9%. If you're only talking about the front of the head or the back of the head, it's 4.5. Okay? If you're talking about the entire right arm, it's 9. If you're talking about the front or back, it's 4.5. Okay, you see where I'm going with this? The trunk is split up into 36%. So if you're looking at the front of the trunk, it's 18%, which includes the entire front of the chest and the entire abdomen, right? 9 plus 9 is 18. And then if you're looking at the posterior, where the entire back is 9% and the whole lower back and pretty much sacrum is 9%, where you get 18 and 18, which is going to equal your total. If someone has 36% burns around circumferential around their entire trunk and abdomen, that would be extremely severe, where we have a huge risk for abdominal and thoracic compartment syndrome, where that patient's airway is going to be a huge issue. Breathing is going to be difficult. Their organ functioning is going to be difficult. So this is something that I really need you to understand and be able to figure out. So I need you to know this chart. Okay? Are we okay to move on? Okay. The extent of your burn injury. So a minor burn, second degree burn of less than 15% in adults or less than 10% in children. You could also have a third degree burn of less than 2% that doesn't involve a special area like your eyes, ears, face, hands, feet, perineum, or joints. And this also excludes all patients with electrical injury, inhalation injury, or concurrent trauma, and all at-risk patients. So these are your patients that, yeah, it sucks that you got burned, but it's not that bad. And I want you to also see, too, it says, all at-risk patients are not included in this. Okay? So then you have your moderate uncomplicated. This is second degree burns of 15 to 25% in adults or 10 to 20% in children. I told you there's a difference when it comes to big people and small humans. There is a big difference. Third degree burns of less than 10%, not involving those special care areas which are listed above. I would say it's probably important to know those special care areas. And this excludes all patients with electrical injury, again, inhalation injury or concurrent trauma, and all at risk. So why inhalation injury? Have we all, or at least some of us, watched This Is Us? Oh, such a good show.
Yeah, I did.
I don't want to tell you what happens. I swear to God, that episode, I cry. I'm not gonna kid. I cry. I literally cry. Smoke inhalation is extremely dangerous. It was also on a Grey's Anatomy episode where there were a bunch of burn patients, and I believe it was Alex Karev that cleared the patient to go. And I don't remember, actually, I think it might have been April. I think it was April in her first year when she left. She didn't look in the patient's mouth. She didn't look at the back of the patient's throat, because if she would have seen signs of smoke inhalation, and she would have been able to at least make sure that the patient was monitored correctly and know that there was a possibility that this patient was going to go into acute respiratory failure. And if that isn't caught, that patient can absolutely die from smoke inhalation. It's very, very, very dangerous. And then we have major burn injury. This is second-degree burns of at least 25% in adults, at least 20% in children, all third-degree burns that are 10% or more, all burns that involve the eyes, ears, face, hands, perineum, and joints, and then all patients with inhalation, electrical, or concurrent trauma, and all at-risk patients. I would become familiar with this slide. Okay, Parkland formula. This is the way that we figure out how much fluid your patient needs within the first 24 hours. So it is 4 milliliters times the patient's body weight in kilograms times the total body surface area. Half of the amount of fluid will be given in the first 8 hours. The remaining half will go over the next 16 hours. So this will be the total amount of fluid over the first 24 hours. I would not be surprised if you had a picture of a human that you had to figure out the percentage of the patient burned, have to figure out their weight in kilograms, do this formula, and then be able to tell me how much fluid is going to be given in the first 8 hours and how much fluid is going to be given in the next 16 hours. And I would probably also assume that that question would be worth many multiple points. The most important thing for a burn patient is to stabilize the patient and get them to a specialty burn center. As soon as that patient is stable, they need to go to a specialized burn center. We do not keep these patients on regular old floors at Akron General or St. E's, Maine, or Mercy or Altman. They have to go to a specialized burn center. Ooh, this is a very busy slide. So, care of the patient within the emergent phase. First aid, prevention of shock, prevention of respiratory distress, detection and treatment of contaminant injury, and then wound assessment and initial care, which is your debridement of that eschar tissue. So, what is our number one priority on this list? Our airway?
Airway.
And then what's our second priority?
Prevention of shock.
Prevention of shock. What kind of shock do you think this patient is going to go into?
Septic.
Hypovolemic.
Yeah.
Most likely hypovolemic shock. Could be a different type of shock depending on the burn, the location. But most likely because of the fluid loss and depending on the total body surface area and the degree, it would be hypovolemia. So, of course, the first thing we want to do is extinguish the flames. I mean, that's just silliness. When clothes catch fire, the flames can be extinguished if the person falls on the floor or ground and rolls. We learned how to stop, drop, and roll in kindergarten. Maybe even before that. I bet you my 3-year-old practices that at school. Stop, drop, and roll. You can also smother flames using a blanket, rug, or coat. Standing still forces the person to breathe flames and smoke, and running fans the flames. If the burn source is electrical, the electrical source must be disconnected. That makes sense. And like the Grey's Anatomy episode that we talk about often, if someone has gotten an electrical burn and they are in a pool of water, water is an electrical conduction system, and you will then also get electrocuted in the basement of the hospital. So, what feeds fires? Oxygen.
Air.
feeds
Oxygen.
fires. So if you are running around caught on fire, you're just making the flames worse. I feel like we've all really learned that throughout our years, and if we haven't, we should probably talk. Cool the burn. After the flames are extinguished, the burned area and adherent clothing are soaked with cool water briefly to cool the wound and halt the burning process. Once a burn has been sustained, the application of cool water is the best first aid measure. Soaking the burn area intermittently in cool water or applying cool towels gives immediate and striking relief from pain and limits local tissue edema and damage. However, never apply ice directly to the burn, never wrap the person in ice, and never use cold soaps or dressings for longer than several minutes. Why? Thank you. I've said it multiple times. The more you're burned, the more your body is capable of regulating your temperature. Especially if it's a small human or an elderly human, if you submerge them in cold water and they are burned, not even really severely, and they've lost their ability to thermoregulate, they are going to become hypothermic. You want to remove restrictive objects. If possible, remove the clothing immediately. Adherent clothing may be left in place once cooled. Other clothing and all jewelry, especially rings, because of what?
Swelling.
Edema.
Compartment.
Swelling, because they will have to cut that ring off. Including all piercings should be removed to allow for assessment and prevent constriction secondary to rapidly developing edema. You want to cover the wound. The wound should be covered as quickly as possible to minimize bacterial contamination and decrease pain by preventing air from coming into contact with the injured surface. Sterile dressings are best, but any clean, dry cloth can be used as an emergency dressing. Ointments and salves should not be used unless prescribed by the burn center. Other than the dressing, no medication or material should be applied to the burn wound. Healing burns is very specific. It's not like any other wound. And then irrigate chemical burns. We've already talked about this multiple times. Chemical burns resulting from contact with a corrosive material are irrigated immediately. Most chemical laboratories have a high pressure shower for such emergencies. If such an injury occurs at home, brush off the chemical agent, remove the clothes immediately, and rinse all areas of the body that have come in contact with the chemical. Rinsing can occur in the shower or any other source of continuous running water. If a chemical gets in or near the eyes should be flushed with cool, clean water immediately. Outcomes for the patient with chemical burns are significantly improved by rapid, sustained flushing of the injury at the scene. The very, very first thing we do for a chemical burn is to douse it and drown it in water, running water, to try to get it off as fast as possible. That's also why if you ever work in a place that has chemicals, really it's an OSHA regulation everywhere, that we have, what are they called? Material safety data sheets, MSDS books. It's always part of all of your training everywhere, that everywhere has to have one. We even have one here. And it lists every chemical that you have within that facility and what to do if you are contaminated by it. Care of the patient in the acute and intermittent phase. Pain management is going to be really important. We all know how painful burns can be, and it is generally severe. Patients experience background or resting pain, procedural pain, and breakthrough pain, and opioids remain the standard of care. Nutritional support, because there are going to be metabolic abnormalities, when your body is in such a critical place, you are burning up calories as fast as possible because the way that your cells need energy to regenerate and heal, that's using all of your energy that you have. So malnutrition can happen really quickly when it comes to burn patients. Complications of immobility must be avoided and emotional support must be provided. Complications of immobility, that is how you get that contracted skin. If your body is allowed to heal in one position and it's not moved and exercised and dressed correctly, you, because of those contractures, may lose function of that joint or hand or foot. Rehabilitation often extends for years. Reconstructive surgery to improve body appearance and function is often needed. Like I said, we do a lot of laser therapy at Children's, and I'm sure at every burn center in the country. Elastic pressure garments are used to prevent hypertrophic scarring. We all know what a keloid scar looks like. This is keloid scarring on steroids. I mean, this can become huge, raised, scarred areas. And the thicker that scar is, the more immobile the person will be in that area. And then multidisciplinary continuing care must be organized. This could involve a lot of things. If they have comorbidities, this could involve cardiac, this could involve pulmonary, this could involve mental health. I mean, could you imagine having severe burns, especially on your face or your hands or your arms or your chest or somewhere that people can see it, and how that's going to affect you for the rest of your life? So we have a little case study. Mr. Travis is a 32-year-old male who presents to the ED after sustaining severe second and third degree burns in a house fire. The below diagram estimates his wounds. He weighs 85 kilograms and is 5'11". So first, let's figure out the rule of nines and figure out the amount of the body that is burned. You can also, when you're looking at the body, you can also try to break it up into smaller quadrants too. So if you're looking at the head, we know that the posterior of the head is 4.5, right? And the head and neck. So what if we, from the neck, draw a line up and across and break that up into 4, right? So now you're looking at one quadrant within that 4.5%. Does that make it easier or harder?
That makes sense.
Makes sense. I feel like it makes sense. I
Half the arm, so which is split upper and lower.
Right. So usually it's anterior and posterior, but in this case, we really are talking about the upper half of the arm. So, and it's burned front and back, circumferential. So if I were looking at this, I would say half of that arm is completely burned. And if that whole arm is 9%, I'm going with 4.5 because half of that arm is burned. that make sense? Let me know what numbers you come up with. Anybody online?
$46.3, but that's.
That is very, very close to right. What?
That's 43.
Very close to correct. Anybody else? And that's a little high. And we call this an estimate for a reason. I mean, the body isn't just like broken up into these quadrants. So truly, this is an estimate. What'd you
I
get,
got
Jade?
43.
Very close.
Oh, mine's is low then. I got
The answer
37.5.
is 40. The answer is 45.
Oh,
45%. So we have half of this arm. I'm gonna call that corner. We have half of that abdomen, front and back. So the front is 9, the back is 9, right? And half of the abdomen. So on front and back, so I'm gonna call that 9. And then we have definitely more than half of the chest. Definitely. So this is really where your estimation is coming in, okay? So the top half of the trunk is 9 and this is the front. The top half of the front is 9, the top half of the back is 9. So if we were to say I almost want to call it 8. Like I feel like it's almost taking up the entire front of the trunk.
5
Yeah,
to make 16.
8 on each side to make 16. Correct. I feel like that's a lot of the trunk. Then we have half of the left leg. And the leg is 9. Yes?
Front, back, 9 each. Yeah.
Front and back 9 each. So 9 at the front, 9 at the back. Okay? So I would call that half of the leg, and it's circumferential, which means it goes all the way around. So what are we gonna call that?
Each side.
Well, you said it's on each side, right? So
Mhm.
let's call that 9. Okay, so then we have this little portion of the face. What's 1/4 of 4.5?
1 point.
It was like 1.12. But I just made it 2.5
5.
front and back.
Because it's front and back.
I did a
Yeah.
2.5 too.
Said it. We just called that like.
So
So
4, 6, 7, 9 plus 9 is 18. 16. We have 8 plus 6. It's 24.
So it's not covered. That would suit the on both sides. Well, face. Each so. I think to get 45, you have to give the base 4.5%. Half of the base interior.
Yeah, you have to give the face more.
To make
Yep.
45, you have to give.
I agree because it's front and back.
Yeah.
Oh wait, no, because we already did that.
Yeah, it should.
Right.
This is
I
gonna be
gave
really
you 2.5 for front and back.
Yeah, I agree.
But they had to give the face more to get 45
Unless they give something else.
or something
So
else.
with calculations, I got 41,
Mhm.
Did you say the base was?
2.5.
So, I mean, like I said, this is very, very much an estimate. So I guess, could you say that the arm is more than half? Yeah, I guess, right? It does come
Yeah.
past the antecubital. So I guess we could add 1% or 2 for front and back, right?
What'd you get for the
And
trunk?
then we have this little teeny tiny burn that's on front and back of the lower part of the leg. So could you add a percentage from that? Sure.
So
Yeah.
when this is on our test, are
She
we
got
gonna
8 for the trunk on me.
or is it just gonna be a very obvious?
So I think what I'm going to do, what I think would be the most fair is to give a range. Like, because we've discussed heavily how this is an estimation, right? So if you were to say, because I got 41, you got 43, what did you get? 46. So I feel like it would be, for me, I would put like A is 40 to 45%. B is 45 to 50%. C is, you know what I mean?
What if somebody gets 46?
Well, that's what I'm saying. You need to really look at where your numbers are coming from.
Well, it's obvious it's not 50%. Like we.
Well, it's definitely not 50%.
We should have.
So whoever, because Clem got 47 too. So how did you come up with, where did you get 47?
So the head I did 2.5.
Total,
Yeah.
not front and back,
And
because that was already front and back.
arm 9, leg 9.
Mhm.
Trunk was 27.
Are you counting the trunk and abdomen together?
Yeah, because I did 36 and then divided it in 4 quadrants, and it's basically just a little section off. So I took away 9 for that.
Okay, so I wouldn't do that because there's a
No.
reason that the abdomen and the trunk are separate, like the chest and the abdomen are separate on the diagram.
Mm-hmm.
So, because I really went with the diagram. Because I would say that abdomen is really half. So, and the trunk isn't completely covered. So only taking away 9 from that 36 isn't enough to take away. Because this is truly half in the abdomen and the trunk is also missing a burned section. So if you look at it from like, if you separate the trunk and abdomen, do you see where I'm coming from?
Yes.
Brianna, what about you? Did you do the same with the 36? Okay. Okay. So next, we're going to calculate the Parker's formula. Parkland burn formula.
So what's the number we're going? I've got 46 too. But what are you doing? At 40. I'm 40.
How many kilograms is he?
It's 85.
85.
Thank you.
I'm trying to think about my answer to you. By the way, I'm not ignoring.
You said the answer was 45, like, or was it 41?
I like personally, I got 41%, but the paper says 45%. So if
That my paper, I don't know how to explain it, but if you look at it, that makes sense. That's me. I just want you to see how I got what I got.
I'm like, I got 43. 43.
I'm just,
Yeah, go 45, because I want you to be able to do this formula correctly.
Okay, 45.
not have to edit my. If I do. So 153. Should be.
Is it 153%? I mean, yeah,
I think about 20,
I got
Are
153.
we doing MLs?
No, it's in percent.
Look at the formula on the previous page.
You would convert that 45 to percent, so it would be 0.45.
So we would only give 153 mLs?
If that's what.
That don't make sense. I thought it would be 1,500 mLs in the first. I don't know.
No. In the first 8 hours, you get half the amount of the fluid given in the first. So when it be 153, it would be half.
Okay.
But that don't seem like a lot.
Okay,
100.
time out. So 4 times 45% times 85 kilograms equals 15,300 milliliters.
That's what I
mLs.
got.
So if you had to give half of that in the first 8 hours, what is half of 15,300?
7650.
Are you sure?
You have to think we drink more than 153 mLs in a day. So it has to
And
be
you have
15.
to also remember that if a patient has 45% of their body burned, that means that they literally are not holding on to any of the fluid in their bodies. He has second and
You've
third
lost
degree
me
burn.
The reason
because
why
I
you're
typed
losing
in
me
4
because it
mLs.
says percentage. So I'm converting it into a percent.
That's
You need to
If you
convert the
change it to a
percentage into
decimal,
a
it's
decimal.
slower.
You have to.
No, there is no change in that number to a decimal.
why would you change it to a decimal?
You just keep the number as the number. I think you're letting that percentage sign confuse you.
Right. That's crazy.
Yeah, if you change it to a decimal, you'll get a smaller number, the 153.
No, you're correct, because if you change it to a decimal, then that means that you're finding the percentage of the percentage, which we don't need to do that. So she's correct. We don't need to make it a decimal. It's literally 4 times 45 times 80.
So with the formula, just ignore the percentage. Like, don't put the percentage in it because obviously
it's
when
the
you put
percent right
45,
there.
it's going to
That's
make it
what's
low.
Right, because we've already have the percentage. We're not looking for the percentage of something. We already have the percentage of that something.
No, I
percentage is
understand.
your
I
body,
just plugged
the
it in
burn.
exactly how it said.
Just because I don't even know what
This
those
is
calculators
interfering
do.
with the FiO2
I think that's what I
thing.
confused.
Oh, because it's changing it to a decimal. Yeah, we don't need to do that.
But
Well, hold on. I'm gonna talk to the boss lady about that. I just want to make sure that we can figure out how to do all of these things. Okay. So on these calculators, does it have a percentage thingy? Like if you were to click 4 times 45 and then hit percent,
Yes,
like I
it will
don't want
switch
you
it up.
doing that.
Okay.
Yeah, do not
Thank
do
you.
that. Do not do that. And we don't use high-tech calculators to do all these high-tech fancy math. I want you to remember that this is just simple math. This is simple multiplication. Okay? One number times another number times another number. So now we need to figure out, we have the total. So now I want you to figure out milliliters per hour for that first 8 hours.
So it's 56. 50 divided by 8, 9, 6, 14. Per hour, or you want per hour? Yeah.
Milliliters per hour.
So 956.3.
956.3.
Because milliliters per hour are rounded to the 10. So this is going to be 956.3 milliliters per hour for the first 8 hours. Well, first of all, before we move on, what about the 16 hours? So what's the other half? 7,650, and we have how many hours?
16.
So how many milliliters per hour for the remaining 16 hours?
478.1.
0.1. 478.1 milliliters per hour for the remaining 16 hours. Do we all understand how we got those numbers? Because Christy's going to come in here and she's going to talk about, in a better way than me, about how she got 45% because I want to hear it too. Because I want to be able to teach it the correct way. And how are we supposed to not get an estimate? Because that's just really hard. And how are we all supposed to land on the same exact number? And then how are we all supposed to land if we all have different first numbers? How are we all going to land on our resuscitative measure?
I mean, I know like what we're learning now is supposed to define them, what they be yours.
Yes. So what is our top nursing priority?
Respiratory.
I agree with both of you. So they said thermoregulation, airway management, and fluid resuscitation. We saw on Mr. Travis's little body that half of his neck is burned, which I just told you, and most of his chest is burned. And I just told you that if that's the case, we're talking about a really serious airway management situation here. Okay. So I truly believe that this paper says fluid resuscitation, which yes, it's very, very, very important that fluid resuscitation needs to be started immediately. But at the same time, we also need to realize in our critical thinking and judgment brains that this patient may have a impending airway situation. So yes, if you are the nurse providing care in the ER to this patient that has just arrived, your patient has a patent airway. He's sitting there in front of you. Yeah, he's in pain, he's hooting and hollering, but guess what? He's breathing. Because he's sitting at 98%. So what is our top priority? Fluid resuscitation. If you're looking at it without all the information and you're thinking about the neck and the trunk and the chest and all of these things, you also need to ask yourself, is my patient having impending breathing difficulty right now, right in this moment? Does it say it in the question? No, it doesn't say it in the question, which means it's not happening. Because we're in the perfect NCLEX world, where if it doesn't say it, it's not happening. And if it's not implying it, it's not happening. Make sense? All right, I'm just going to finish this because there's only a couple more slides and then we're going to take a break. So you note circumferential burns around the right upper arm and soot around the mouth with singed nose hairs, plus some facial swelling. What are your main concerns?
Bone inhalation.
I agree. What do you say? Did you hear them?
Did they say smoke inhalation?
They did, ma'am.
Okay.
And they also threw in compartment syndrome of that right arm. So, airway, of course, due to possible likely inhalation burns and airway swelling. And then we have compartment syndrome due to circumferential burns around the right arm, which was perfect. Physiologically, explain the alteration in Mr. Travis's vital signs. So I'm assuming they're talking about the ones on this previous page here, where it says his vitals, his blood pressure is 90/48. His heart rate is 108. Oh, it's not on your paper, it's on mine. His blood pressure is 90/48, so he's hypotensive, yes. We have a heart rate of 108, so he's tachycardic. We have a temperature of 97.2, and pain is 10 out of 10.
Fluid loss,
98.
hypovolemic.
Agreed. So he's hypovolemic, which is probably causing his hypotension, which is also causing his tachycardia
Tachycardia.
because his heart is trying to compensate with more cardiac output to increase his blood pressure. What is also happening? He's hypothermic. Maybe not completely, maybe not very much hypothermic right now, but 97.2, that's on the low end. That's on the low end. That is not normal in any way, shape, or form, especially for a burn patient. So, and we know that a huge surface area, total body surface area, is being affected. So he is unable to regulate his thermoregulation whatsoever. Okay. How will you know if fluid resuscitation is effective?
Blood pressure.
Blood pressure will
Heart rate
raise. He wouldn't be tachycardic anymore.
Okay. So I love that. Love that. He could still be tachycardic because of pain, so remember that. But it could help his blood pressure, which I'm hoping so. What is something that you are not even thinking about whatsoever that we could
The skin.
urine output?
Oh.
Urine output. How much urine output do we need from a healthy human per hour?
30 ml.
3 mLs per hour is the least amount of urine that a normally functioning human should be making, right? So, fluid resuscitation should be at least 0.5 milliliters per kilogram per hour, or we all know that it has to be at least 30. Okay. Mr. Travis is intubated for airway protection and taken to the OR for surgical debridement of his burns. He is then transferred to the burn ICU. What are priorities for daily care for Mr. Travis?
Make sure. Getting up, fluid being up.
Okay, fluids, urination,
Wound
keeping
management.
him warm.
Wound management.
What'd you say?
I said wound
Pain
management.
management? Oh, wound management, yes. And pain management, by the way. So infection prevention is huge because I've said it lots of times. He's 45% burned. That's almost half. We basically should call it half of his body is burned, has open, weeping wounds. So infection prevention is huge. Meticulous wound care, sterile dressings, pain control, maybe even a PCA pump. I mean, dude's intubated in the ICU, he's probably on a fentanyl drip. Let's just be honest. Okay. Manage ventilator and respiratory needs, of course, until we're able to extubate. And then maintain temperature and hemodynamics is going to be very important. Mr. Travis will need skin grafts. How will you explain autologous skin grafts to Mr. Travis and his family? Which we literally haven't even discussed it. Okay, so what does auto mean? You are correct, by the way. So it's from your own body, okay? So I can tell you, because I have been a part of countless of skin graft surgeries, which, by the way, burn surgery is my least favorite because it is very bloody and very barbaric and very horrible. So what happens is they get this thing called a Pitkin, and the Pitkin is a pressurized needle, like kind of like a gun needle, and they use a mixture of saline and epinephrine. They go into that healthy tissue, which is usually if they have access to it, is like a thigh. And the surgeon will inject that saline and epi into that area, which is about this big. And what happens is that it causes that tissue to become really taut. So like tight and swollen because you're putting fluid in there. And then the epinephrine causes vasoconstriction, which is causing decreased blood flow to that area. So hopefully it has less bleeding, right? So then they take these little things called towel clips that look like little lobster claws, and they put them on each 4 corners. And one person has the top and pulls, and the other person has the bottom and they pull, so that skin is as taut as possible. Then they get this thing called a dermatome, and it goes zzz, and it's connected to the wall where the gas is to give us power, and it goes zzz, and shaves a whole layer of skin off. And then depending on the size and the severity, then you go over to the dermabrader, which can be 1-to-1, 2-to-1, or 3-to-1. And this is where you see mesh, where they can create mesh from your own skin. So if it's a very, very large burn and they need that meshed skin to stretch across a big area, then you're going to have bigger meshing, like a 3-to-1. Hopefully they don't have to mesh it at all and they can just use that skin. So then that skin is then placed on you and stapled or sutured, depending on the surgeon, all depends. And then you are then dressed, and the burn center usually sends their own nurses up. They come in their little bunny suits, and they come in, they put all the dressings on, and then the patient goes whoop, right back to the burn center. So autologous skin grafts are the best situation. I would definitely, if I was in this situation, want to use my own skin, because we talk a lot about cadaver things. Cadaver skin is not capable of actually staying on the body. It gets put on the body to provide protection for healing tissue. And then in a couple days, they have to go back and they have to remove that cadaver skin. So cadaver skin isn't very good for autologous grafting. Another thing that is really exciting that they talk a lot about in TV shows, but actually hasn't become a thing until very recently, is spray on skin. It's called RECELL. We use it at Akron Children's, and it's very, very cool. We take the patient's own skin cells, literally like muddle it up. If you had, what are those things called? mortar and pestle, like literally like grind it up, put it in a solution. That solution breaks down those skin cells and makes it like a skin perfume, Jesus. Yes. Some type of like a skin spray. It literally comes with a bottle with a spray head that and it's all sterile, and that they can literally spray it on. They can scrape it on, they can pour it on. There's so many ways that they can do this. But it has really changed the game when it's come to burn healing for a lot of patients. And it's really, really cool. And that concludes our burn lecture. Any questions on burns? The first degree slide, way, way, way back when. This one?
Yes.
Wow. So I would expect you with burns, like I said, we're gonna have Christy come in and explain to us how we're going to get the same number on our test. And also I would expect you to know both formulas, how to figure out the percentage of body, that was burned. I expect you to know that Parkland's formula. I also want to know about airway management and compartment syndrome and the complications that can occur from these burns. I want you to be able to tell me how you treat the different types of burns. And then complications are huge. So if you are the